Thank you, Shelley, and thank you all for attending this really important conference to try to determine and to try to create a vision for tools to be able to bring the great talents of people who are working on brain disease to the people who need those talents throughout the world. And I'll try to give you a little perspective around the developing world, but the confluence of interest in the developing world, as well as what we're facing here in the United States, is catalyzed by a tremendous opportunity for behavioral health, and that's population health management. The notion of essentially being accountable for populations, being responsible for public health outcomes, for reducing the burden of disease, and for improving the quality of health has a mutual interest in, hopefully, the redesign of the American healthcare system in the fits and starts that it's in right now, and in bringing access to healthcare for those of the poorest people in the world. And the challenge is making certain that in the awareness of the design of those systems, those who design them, as Dr. Duckworth, I think, articulated, realize that those people have brains and they also have genomes, and they also live in a society that's associated with a number of stressors and toxins that affect their behavior, no matter what zip code they're in. And additionally, that there isn't the human resource anywhere in the world that has the ability to deliver to the need. The burden of disease associated with depression will be number one among all diseases by 2030. It's about number two or number three, depending upon the calculus. And in terms of lives lived with a disability, by 2025, it'll exceed all other infectious and non-infectious diseases. That's pretty remarkable for where I work right now, in places where there really is no organized psychiatry or psychology. And access to care, and we were describing it here. I think Scott started off talking about it yesterday. Ken talked about it right now. Even within a place where the resources are abundantly rich, feel like they're inadequate to meet the need. And let me give you a balance in that regard. There are about 1,000 psychiatrists in Newton, Massachusetts. There are about 40 psychiatrists in Wyoming. When I landed the last time in Liberia, I was the only psychiatrist there. And for the 4.6 million people who live in Liberia, which just got over 20 years of civil war and then the worst outbreak of an infectious disease with Ebola essentially in modern history, putting aside multi-drug resistant tuberculosis, which sits there and it remains a pariah. At the present time, there are 45 doctors to take care of about 4.5 million people. So if we don't figure out how to use tools that bring expertise that's concentrated on this street, in this neighborhood, in San Francisco, California, around Dr. Geste in San Diego, in Paris, France, or in Moscow, to the people throughout the world, we will lose the mission of this institution and the mission of the institution that I work for, and that is really understanding that health is a human right, and that providing health care is fundamental to the way in which we need to be able to live lives and to understand that our neighbors need to have their mental health addressed as well. So the question is, how do you do that? For Partners in Health, as Shelley described, is a global health organization that you may know about, that was founded by Paul Farmer and Jim Kim, who's the head of the World Bank, and Ophelia Dahl, a couple of their colleagues about 30 years ago, with the principle of providing moral treatment to those, with the principle of being able to essentially provide a preferential option for the poor. Moral treatment is actually the notion of the same principles that McLean and Friends Hospitals and others were founded around when the Quakers brought scientific method to providing behavioral health care here about 2 centuries ago, and there's a confluence of interest in that regard. The notion of providing a preferential option for the poor means that no matter what zip code you happen to be born in, you deserve the same kind of care that somebody who lives close to the Brigham Children's Hospital or McLean Hospital is able to have. And there's a long distance between those kinds of outcomes. And so Partners in Health is in 10 countries providing that kind of care, largely in very rural settings, taking care of about 8 million people. And those countries are Haiti and Rwanda, Sierra Leone and Liberia, Lesotho, Malawi, in the slums of Lima, Peru, in Siberia, Chiapas, Mexico, and in the Navajo Nation. And in all of those places, access to services, because of the rural condition, because of the impoverished nature of those environments, because of the lack of their infrastructure, essentially, as well as the confluence of difficulties in the social determinants of health, housing security, food security, water security, education, reduction in violence, essentially cause remarkably horrifying outcomes, even in the context of the presence of medical science on the same planet. So maternal mortality rates in Sierra Leone, Liberia, and Lesotho are about 1,100 per 100,000. That means that there's a 1% probability a woman will die in childbirth each time she gives birth, and about a 6% probability that'll happen over the course of her lifetime. And in those populations, people have precisely the same genome. They may have shorter life expectancy, so the confluence of illnesses are different, but the prevalence of schizophrenia, of bipolar disorder, of major depressive disorder, of anxiety disorder, and panic, in addition to those disorders that have much higher incidence of prevalence rates because of the association of trauma, are extraordinarily high. And the complete absence of focus in terms of policy and investment, as well as the delivery of those services, causes catastrophic outcomes overall, shortens life expectancy and the quality of life, and has deep effects on child development because of the effects of those psychiatric illnesses on mothers and fathers who are caring for those individuals. So the technology that Partners in Health has used for the past 30 years has been to find the genius within the communities we serve. And that is to train community health workers to first focus on infectious disease, maternal health, perinatal care, primary care, malnutrition, and then was fostered by investments in HIV and tuberculosis. We've now leveraged that model really under the visionary leadership of one of the members of our community, Beppe Raviola, who runs our behavioral health services, to try to leverage and to task shift those services to community health workers so that they can identify and screen, be able to do population surveillance, bring access to formulary, as well as to do, with supervision, evidence-based therapies for specific psychiatric disorders, particularly depression and anxiety. So the question is, how do we use technology and resources in a way that allows us to have access to care here, in places where there's an abundance of providers, but not where people need that care or necessarily focused on the highest level of severity of illness, or with a geographic dispersion that is very, very difficult to be able to manage, or in the developing world where the skill base isn't there, and how do we take the skill base and bring that science? So one, this university has been very invested in developing remote teaching tools to be able to make access to the curricula that exist here readily available on interactive platforms. However, there's been very little use of those around training in remote places. So one, to train community health workers, to train psychologists, social workers, primary care physicians, and nurses in models that allow those teams to bring various levels of skill to the community depends upon having firm boundaries and firm infrastructure on the teaching side and remote teaching tools overall. There has, as we've seen in population health management here, overall on the primary care side, as well as increasingly on the mental health side, we need to understand what skills can be transferred, where tasks can be transferred responsibly. But that also means that we don't settle for the fact that people who don't have proper education are taking on decision-making and who don't have experience that goes far beyond their ability just to save money, or because essentially this is okay for poor people who are in distant places. If we're going to task shift, we have to do it with constant nurturance, intense auditing of what those skills are, constant retraining, and a variety of different ways of doing intensive supervision synchronously and asynchronously. So people to be able to report their cases, to be able to send them online to people who are supervising them many, many miles away, to share their cases and to get responses back about how to manage in a certain circumstance, where there can be group learning, and synchronously so that patients can be seen as well by providers vis-a-vis telemedicine, or to do supervision in real time. The question, how do I take the 12,000 community health workers that we have throughout the world and allow them to go from using pencil and paper to be able to essentially use the PQ9 on an ongoing basis, to be able to, and there are translatable and culturally correct versions of depression screening, psychosis screening, anxiety disorder screening, disorders in children, developmental tools as well, to be able to use those in a way in which the data have value as opposed to being collected massively. And now that there are more easy to access smartphones and other handheld devices, the ability exists to do that. Unfortunately, in much of the developing world, bandwidth is a challenge. I think over the next 3 years we'll be able to face that. There are 3 satellites that are going up that have the kind of satellite technology that you get with Fly-Fi when you're in JetBlue, that essentially will bring true broadband access to all of the world. We've used handheld devices to be able to treat cholera in Haiti, to treat and to do surveillance with Ebola, and now to do general screening in populations in several different sites. Again, the notion of telehealth is critical here, even for small snapshots of clinical presentation. Very, very short vignettes that can be shared or that can be, in fact, videotaped, can in fact be video recorded on devices and then downloaded when people are within range of bandwidth to describe and reinforce both teaching as well as clinical conditions, and then to be able to start to bring point of service to the field, where lighter and lighter devices will allow us to do diagnostics, imaging, and other elements in the field itself. This will save tremendously in population health management here in the United States as we take people out of bricks and mortar infrastructure. For us in the field, it's life-saving in places that have very little resources and that are spending less than $30 per capita on healthcare, in contrast to the $10,000 per capita we're spending here. The other question is, how is it that we can bring physicians, psychologists, social workers, and nurses to teams? One, clearly we're going to have to empower the public health infrastructure. So public health nurses who are managing teams, working together with social workers and psychologists, need to both have teams of community health workers. They then need to know in an ongoing way with the data that I just described when supervision is necessary, when virtual supervision and virtual visits are necessary, when we need to have somebody from here see somebody there in the field, whether it's in Wyoming or in Freetown, Sierra Leone, but also how to essentially reinforce the therapies that people are learning and to make sure that they are using those evidence-based practices. And data are critical. For us, data at a basic level inform the supply chain. In all the countries in which we operate, the supply chain is managed usually by the country with some other funding. There are constant stockouts of virtually every kind of medical equipment, and certainly the formulary. Most of the formulary that they're using psychiatrically is 1950s formulary. I often see people being treated long-term on amitriptyline, and the only available antipsychotic is chlorpromazine or thioridazine. And whatever else was left over, but still is supplies in those venues. So there needs to be a completeness of formulary, but there also needs to be an ongoing notion of what the demand is, epidemiologically, as well as services are created and there's a higher degree of utilization. And then, essentially, using those data, one can start to determine where the risk is in various populations, to basically do true epidemiologic research, to understand what components of stress truly create higher risk for a variety of different disorders, so there's the opportunity to do prevention and intervene at the quickest possible level. So the opportunity in the developing world is precisely the same as it is here. The cross-translation is the true opportunity, and alpha sites exist in the field for all the technologies we describe. It's a little bit more difficult to do virtual therapies, clearly, to use text messaging to do therapy, or to basically to do therapies with providers who are at great distances, except when they're planned, except when essentially there's another individual who is the go-between who's really taking care of the patient on an ongoing basis. But population health management, whether it is with the poorest at greatest need or here in the United States, is the opportunity. In every single population that we'll study here, whether it's a commercial population like a self-insured population of Partners, which has about 117,000 people in its self-insured pool, in a Medicaid risk population or a Medicare risk population, one of the top 3 diagnoses is going to be a psychiatric diagnosis. It'll be depression and anxiety together with maternity and low back pain in a general population, could be cancer, disability, heart failure, and diabetes together with major depressive disorder in an older population. And the interface, as well as the comorbidity, will cause greater disability, poorer outcomes, and greater cost no matter where you are. So the opportunity to intervene with these efficiencies is tremendous and exciting. Thank you very much.